everyone, welcome back. I want to welcome Dr. Staci Tanouye. She is a board certified OBGYN. She practices in Jacksonville, Florida. And today we're going to be talking to her about all things HPV and Pap smears. And so welcome. Thank you for being here.
Thank you for inviting me. I'm so excited.
Yeah, no, I'm like, this topic is super fascinating. So many misconceptions out there. So before we get into the meat of it, can you just sort of give us a little bit of background, how you got into how you got into OBGYN and how you got into women's health and what brought you here?
Yeah, definitely. Let's see. I did my undergrad in medical school in St. Louis, and then I did my OBGYN residency up at Mayo Clinic in Rochester, Minnesota. And from there, I chose OBGYN because women's health was always so fascinating to me. And I was interested in peds, and I was interested in medicine, and I was interested in OBGYN. But when I did like my OBGYN rotation, people would always ask, well, when the baby is born, like, who are you kind of drawn to more in terms of your interest of what's going on? Are you more drawn to the newborn over at the station, or are you more drawn to what's going on with mom? And me, it was always the maternal side of things. Like, I always wanted to know the background and the history and the intrapartum course and the postpartum course. And that was what fascinated me. So that, and I just love women's health and teaching women about their bodies, because there's so much that women don't know or don't recognize, and so many misconceptions and mistruths out on the internet, that I just really feel passionate about teaching women about themselves so they can feel more comfortable in their bodies and just more comfortable and empowered when they go to their own doctor. So then I did my residency up at Mayo, was on faculty there for a while, and then moved down to Florida.
Yeah, I couldn't agree with you more. I mean, there's so many misconceptions. It's crazy. And being a woman in this healthcare system and having what we think is the internet is supposed to be a wealth of information, I think now is often very confusing for a lot of women. And, one of the main purposes why we are hosting this summit and getting experts like yourself, doctors, to people that need that information, that can, like, reliable evidence-based information, because there's a lot of information that is just out there that doesn't have backing. And
right. I mean, I have even seen sites that are supposed to be the reliable health sites post information that is fairly questionable, not necessarily dangerous, but just questionable in the validity of what they're posting. So even sites that look reputable can have a lot of questionable content. And then you have sites like Goop out there, and that's just, yeah, it's just a whole nother level of things.
Well, I'm super happy that we have you today, because this is a topic that I know a lot of women have questions about, and is extremely valuable. It's extremely relevant to every single woman, pretty much no matter what age you are.
Yes.
So let's get right into it. I'm sure everyone has heard HPV, but just if you could just give us a quick rundown on what it is, high risk, low risk, just to open it up.
Exactly. So HPV is human papillomavirus. There are hundreds of types of HPV out there. And for the most part, what's important to us is that those HPV types are stratified into high risk types and low risk types. Low risk types in general cause things like warts, even just on the skin, on your finger, on your toe. Those are various strains of HPV. Not generally harmful, but they are fairly annoying. There's also a couple of strains that cause genital warts, and those strains are separate from the strains that can cause like warts on your hand and that sort of plantar warts and everything. So they're all different strains. And again, the low risk HPV types that cause genital warts, again, not very harmful. They're not overall going to do anything bad, but they can be annoying. They can cause some mild, minor symptoms. And obviously people don't like the fact that they're there, because it is something that's generally sexually transmitted by contact. All HPV is for the most part transmitted by contact, skin to skin, mucous membrane to mucous membrane. So it's direct touch that is transmitting it. Then we get into the high risk.
Sharing towels. You can't get it from sharing towels.
In theory, there's some thought that maybe HPV could live there, but the risk is so low. It's highly, highly unlikely. So in general, you are not going to get HPV from a toilet seat or from, sharing a towel of some sort. But in good hygiene, you don't want to share a towel anyway. So
Right, right, right. What about like sharing a bathing suit? That might be riskier.
yeah, I don't know the answer to that, but I'm wondering. For the most part, I don't think HPV very lives off of the skin for a very long period of time. So the risk of that sort of transmission is probably pretty low. It would have to be a pretty quick sort of
Right. Which
like
wouldn't
like
want to
I'm
do.
wearing a bathing suit. Wait, what? You want to try it on too? Maybe in that situation, but I can't see a situation of like I tried on a bathing suit from a department store and didn't buy it, and then I really
Yeah.
wouldn't consider that a risk factor for transmission.
Okay. Yeah. And now we're all ordering everything online
Yeah,
anyways. So
exactly.
wash it and then,
Wash your bathing suits.
wash your bathing suits. Always good advice. All right. So you were saying there are different strains, and
Yeah.
you're about to get into the high risk ones.
Yeah, so high risk HPV strains, there's about 14 of them that we are most concerned about. And there are kind of 2 to 3 that are the highest risk strains that we really think cause the majority of cervical cancer. Probably about 70 to 75% of the cervical cancers are caused by the 3 highest risk strains, which are HPV 16, 18, and 45. And beyond that, there's probably another 11 to 12 more strains that have been found to cause cervical cancer. And it's just these specific high-risk strains that we think are linked to cervical cancer and that we think are linked to the vast majority of cervical cancers out there. So we don't think there's a huge genetic component to cervical cancer. We really think the majority of it is due to this particular high-risk virus.
And so when you get the HPV vaccine, and I'm 38 and I
Mhm.
got it, wow, a long time ago now,
Yeah,
like 15 years ago. Um, so I got the older vaccine,
yeah,
like Gardasil 4,
right.
correct? And now there's Gardasil 9, which I think came out 3 years ago.
Mhm.
Uh, what do you say to women that are like, should I go get Gardasil 9 now because it
Yeah,
covers more strains than 4?
it's a really good question, and people have kind of looked at that, and I think the official recommendation as of right now is the answer is no. That the recommendation is no, you don't need to get a new vaccination to cover the other strains. The Gardasil 4 obviously covered 4 strains. It covered 2 of the low risk strains that caused genital warts and 2 of the high risk strains. It had strains covered strains 16 and 18, the 2 highest risk strains. When Gardasil 9 came out a couple years ago, it covers obviously 9 strains. So still those 2 low risk genital wart strains, but then it covered 7 of the high risk strains.
Okay.
Gardasil 4, we think will cover, because we think that strains 16 and 18 cause about 70% of cervical cancers. The 7 strains that are in Gardasil 9, we think that causes about 90% of cervical cancers. So your difference in like risk reduction in cervical cancers is, 70% are caused by these 2 strains and 90% are caused by the top 7 strains. So that's the difference kind of in coverage. And the thought was that that difference of somewhere between 15 and 20% wasn't significant enough to issue a recommendation of people getting revaccinated with the new version. Take that for whatever it's worth. There's no data kind of really one way or the other if giving a whole nother series would confer you a lot more protection, but it's gone off the theory that, yeah, that's the difference between the 2.
And I guess at this point, a lot of women may have gotten it and then become sexually active, in which case they may have already been exposed to
Mhm.
things, and it may not be helpful.
Well, it depends because there's so many strains. We think that even women who haven't had the vaccine, even if you've already had an abnormal pap smear and we know you've got an HPV strain of some sort, we still generally recommend the series because or the vaccination series, because you might have only been exposed to one strain, and that vaccination series will cover 8 other strains.
Right.
You know, the 7 that are high risk, which if you only have one, then maybe you're going to get coverage from the 6 others.
Right.
So no, it's not going to protect you against what you've already been exposed to, but
Right.
there's a lot in there that you could still get some benefit from it.
And I think another recommendation that has changed, and I don't know how recent this is, but the from an insurance perspective, they are now allowing or covering, I guess,
Mhm.
up to age 45 versus before it was like
20.
26.
Mm-hmm.
Yeah.
Yeah, that was very recent. I can't remember if it was just this past October or if it was the October before, but regardless, it was literally just kind of happened that that it got expanded to age 45. So yeah, so now the vaccine is approved from ages 9 to 45, and really insurances should be covering up to age 45 for the most part.
Okay, so yeah, that's great. Obviously I know we see a lot of commercials, and a lot of people, should be talking to their pediatrician actually about getting the vaccine. But it seems to me that what you're saying is that even if you've become sexually active and you're in college, or you're after college, it's still worth getting the series,
Yeah.
even if you haven't gotten it as a child or as a young teenager.
Yeah, I would completely agree with that statement. I think it's always worthwhile. I think even if you've tested positive for HPV in the past, it's still worthwhile. So yeah, anywhere from 9 to 45, regardless of what you've done or been tested for or turned up positive for in the past, I think it could be beneficial because it covers other strains too.
So leads us right into Pap smears, right? Because that's how we that's why we're getting the vaccine, is so we
Right.
don't have an abnormal Pap. And so talk to me about Pap smears, and we can even touch a little bit on how the pandemic has. I mean, maybe women are delaying their Pap smears at this point. I don't know what your experience has been as a physician in this pandemic, or what's going on.
Yeah, it's been kind of crazy. You know, pap smears are, the recommendation is to start at age 21, regardless of if you've been sexually active before or not. And those recommendations are different country to country, right? So Canada has different recommendations, and actually each province in Canada has different recommendations. The UK has different recommendations. Italy has different recommendations. So for the US specifically, right now, our guidelines say start at age 21, regardless of when you became sexually active or if you've become sexually active. And then it should be, if they're normal, every 3 years up until through age 29. And then after 30 and above, it would be if you're doing both pap smears plus HPV screening when you're turned 30, if those are both normal, that screening can be spaced out to every 5 years. So what COVID has kind of done for us, because over the past kind of 15 years or so, the pap smear guidelines have really spaced out dramatically, right? Back in 2000, we were still doing annual pap smears every single year for everyone. And even some higher risk people, we were doing them every 3 to 6 months.
Wow.
So with all the data that we've gotten, most of it comes out of the Kaiser Foundation and their data. We've gotten lots of data to support that HPV and changes of the cervix not only are pretty slow moving in terms of how they progress, but also that the vast majority of them actually regress on their own. So that's been the basis of trying to space out the screening, is that 80 to 90% of women should actually, their immune systems should actually fix themselves. So although you may have picked up HPV and maybe it's even causing some abnormalities in cervical changes, if we give your body enough time to do what it's supposed to do, your body should actually fix it and make get rid of it and make your pap smear and your cervix go back to normal. So if I just wait a little bit of time to let your body to do that, I might not even catch that abnormal pap smear. And then we're going to avoid all the interventions that we know are uncomfortable. So that's the basis behind spacing out the stuff, is that they found by doing that, we're also not missing as much as people are worried about. That's the biggest concern. Well, are you going to miss something? Am I going to get cervical cancer? And they found that no, our rates of detection don't really change very much when we're spacing that stuff out. And that's been to the benefit during COVID, because obviously COVID, everyone's pushing back preventative screening and everyone's kind of putting it on the side table. And I think that's one of the things that for women and people with cervices can be comfortable with, that if you have had a history of normal pap smears in the past and you're just coming up for your routine screening and you've had a normal pap smear in the last few years or so, it's probably okay to push this back. You push your preventative exam, GYN exam, back until COVID is a little more under control. So I think those guidelines and the new research has really kind of helped us reassure women that yes, we are okay postponing your preventative exam. You are low risk, you are healthy. It is safe to do that.
Is there any kind of sexual activity that, even if you've had normal pap smears, like let's say your pap smear is normal, your HPV is normal, you've even had the vaccine, any kind of sexual activity that would prompt someone to come in sooner, or it's pretty much just the guidelines as you mentioned?
It's pretty much just the guidelines. We do know that the higher risk strains are now being implicated in things like mouth and throat cancers and anal cancers. And to date, we don't have any good guidelines of screening for those things just yet. They've talked about things like anal pap smears for years for people who might be at higher risk for anal cancers, who may have had anal sex in the past, and it could be transmitted that way too. Mm-hmm. But those guidelines haven't really come out just yet, although they've been talked about and discussed and looked at for quite a while.
And the oral cancers are fairly rare, from my understanding.
Yeah, oral and throat cancers are fairly rare, but yes, we are seeing that they're being linked oftentimes to HPV.
Okay, that's a little scary.
Yeah.
But it's good to know that they're rare. And let's just talk about, so let's say, if you're a woman watching this and you happen to have had something that's not normal, you've had maybe a normal pap smear, but you've had positive HPV, and so you are someone who's probably going to screen more regularly. So if any one of those is normal, do you go back to annual screenings at that point?
It depends. We have a whole algorithm out there of what different combinations of those tests mean and what we do in terms of follow-up. Okay. And it's different for different age women too. Ages 21 to 24, we think the younger women in that age range really clear this HPV like at very high rates. So we are mostly trying to stay hands off and just kind of monitor if there's something abnormal there that's low grade. We're really just trying to monitor once a year just to make sure that it's still low grade or if that it's going away. For women 26 to 29, it's a little bit different. And then 30 and above, it's a little bit different too. But in general, for most abnormalities, if we get an abnormality and your doctor recommends a colposcopy, which I know we'll kind of talk about in a little bit, most of the follow-up for those, for things that are low grade abnormalities, most of the follow-up we're spacing out a whole year. Okay. So gone are the days of when we are bringing people back every 3 to 4 months and even 6 months. It's quite rare for us to bring in people for a 6-month pap smear follow-up now. So most follow-ups are occurring annually, even with an abnormality.
Okay. And yeah, so let's just talk about colpos. That's kind of the next step, right? If your pap smear is abnormal, you would get a colposcopy.
Correct. Yeah. So if your pap smear is abnormal, again, the algorithm changes by age and the degree of abnormality and if the HPV is positive or not. And there's all different algorithms for the combinations of what's supposed to be done. But in general, if you get a low-grade abnormality, a lot of the times we're going to be recommending a colposcopy, which is basically just a prolonged speculum exam. So it's the same sort of pelvic exam with the speculum that you got the pap smear for, but it's a little bit longer, and we use what we call the colposcope, which is basically like a big magnifying glass, right? It sits outside of the pelvis and we look straight down the vagina at the cervix, and it blows up the cervix for us. So we can see it in a lot more detail. We apply a couple of different solutions that help us identify potentially abnormal cells, and then we biopsy those areas. So that's the worst part about the whole thing, is it does involve these biopsies, which kind of suck, and they are crampy and pinchy, but in general, it should be fast, right? It should be pretty quick. And it's the process of getting tissue biopsies Because Pap smears are just a screening tool, right? They're just a cell sampling that the pathologist is reading. But if we want to see if there's a true abnormality, we actually need a little piece of tissue. And that's where the biopsy and the colposcopy comes into play, is to get an actual diagnosis of what's going on.
Okay, so that's like the next step. And can you do colpos, and does everyone get a biopsy, or sometimes you get a biopsy?
It's a little bit up to kind of provider discretion of what they're seeing and what they do. In general, the general recommendation is, even if you see a normal appearing cervix, it's been shown that random biopsies of even normal appearing tissue might give us a good idea of what's potentially going on that could cause that abnormal pap smear. So for me personally, and this is different provider to provider, I am almost always doing at least two biopsies. And then I'm doing a little sampling of the inside of the cervix called the endocervix. And so I'm typically getting 3 different samples. So I am sure that I get a full, well-rounded picture of what's going on. One of those biopsies might be something directed. I see where I think an abnormality could be, and I biopsy that. And I might do one random one too, just to kind of cover my bases of what I'm seeing.
Any women that really shouldn't get a pap smear because it could lead to like an abnormal result, like if a woman was pregnant, or if she was nursing, or she was on her period, right after her period, or if she had just had sexual activity, any of those scenarios where you're like, well, maybe you should wait for your pap smear because it might just be abnormal for no good reason or anything like that?
Generally, no, we're not necessarily telling people to wait. We think we should keep people up to date on pap smears through pregnancy and nursing. It really doesn't matter if you're on your period or not. Usually, I'll tell people, if your period's really, really heavy, we might want to wait, because it's not a matter of it being abnormal or not. It's just a matter of if the pathologist has too much blood obscuring their sample. So if I can kind of like clear the way and get a good sample with just minimal amount of blood, it's not a big deal. And I can do that like 90% of the time. So women on their periods, I'm usually still bringing them in for their annual exams, unless they say like, I am bleeding so heavily, like I'm just not comfortable doing that. And then we'll reschedule. But for the most part, I'm bringing people in regardless of what they're doing or when or how.
Are there any interventions related to HPV that could affect pregnancy down the line?
Are you getting at like when we have abnormal pap smears and like LEEP procedures and that sort of?
I've heard that LEEP procedures could affect a pregnancy.
Correct. So if you have an abnormal pap smear and you go down the colposcopy route, and if your colposcopy biopsies are showing more severe changes, then we might recommend actually doing a bigger biopsy called a LEEP procedure. So little pinch biopsies are just getting tiny little pinch samples. But a LEEP procedure is actually when we just take an electrocautery loop and literally take an ice cream scoop of the inner part of the cervix out. We're trying to actually physically remove any abnormality that we see and physically remove where the HPV is in the tissues. So it's an actual physical removal of all abnormality in HPV that we're trying to get rid of. In general, we try to be fairly conservative with these types of LEEP procedures, because every time you obviously take a little ice cream scoop out, you're going to shorten a cervix a little bit.
Okay.
The data has shown that one LEEP procedure generally doesn't necessarily increase risk for pregnancy very much. When we think of risk for pregnancy with prior surgeries on the cervix, we think of that cervix shortening too soon and causing things like a cervix that what we call an insufficient cervical insufficiency.
Okay.
So a cervix shortening without any good reasoning that could lead to preterm labor and delivery. So ultimately, it's preterm labor and delivery that risk that we're worried about. The data has shown that one LEEP procedure really may not increase that risk very much, but more than one LEEP procedure does start increasing risk of that cervix shortening too soon and then leading to preterm labor and delivery.
Can you get a LEEP if you're actively pregnant?
We avoid that at all costs.
Okay.
We really try to avoid that, because during pregnancy, your cervix is also super, super vascular.
Right.
And so taking a LEEP in a non-pregnant woman, there's quite a bit of bleeding that we have to control fairly aggressively. And during pregnancy, that is never a situation that any GYN wants to be in. So if you are getting a LEEP during pregnancy, it's because we are seriously concerned about cervical cancer. And you
Right.
are going to a GYN oncologist to be doing that. So a general GYN probably would not be LEEPing a pregnant woman. And we wouldn't LEEP a pregnant woman for anything other than what we're thinking of as potential cervical cancer.
Yeah.
Yeah.
Well, this has been super enlightening. Any other sort of last misconceptions that you want to share with everyone about HPV? I mean, I know there's like so many, but maybe you're like top misconceptions.
Um, all right, so let's see. Let's do like the top two. First of all, HPV is ubiquitous in our world.
Okay.
We think that probably the estimates are upwards of 80 to 90% of people will carry some type of HPV at some point in their lives.
Right.
Again, most of the time your body will kind of clear it and your immune system will get rid of it. You might never even know that you ever had it because your body was super healthy and got rid of it on its own. But we really think that and I tell my patients this all the time, if you are a normal female with normal sexual habits, you are probably going to pick up HPV at one point in your life.
Right.
It may not ever cause you problems, but I can almost guarantee if you've had more than one partner or if your partner has had more than one partner, HPV is floating around in there at some point.
Right. So do
So
condoms prevent against it for our audience?
condoms do reduce, not completely 100%, but condoms do reduce risk. So 100% condom use can be very helpful with reducing all of that transmission. But just because you get an abnormal pap smear and just because you get a positive HPV result, it's not the end of the world, I promise, because like 90% of the people out there will have had HPV. I just happen to catch it in you at this time.
Right.
So it's okay. I spend like the majority of my time talking women off the ledge,
Yeah.
like bringing them down a notch. It's okay. We will be okay. So that's probably number one, is like everyone has HPV or has had HPV, and it will be okay. Second thing is, if you do your screenings as scheduled and as we recommend them, even after you have an abnormal, our job is to prevent you from ever getting cervical cancer. So the people who, not 100%, but like 99% of the time, the people who are getting cervical cancer are people who have missed their scheduled screenings and have kind of put it off and left it. But the vast majority of cervical cancers are slow moving. And the whole point of this whole screening, colposcopy, and LEEP process is to physically remove stuff before it ever gets to cervical cancer. So if you follow up like you're supposed to, we won't let you get cervical cancer, and we'll do our best to not let that happen. And then last thing would probably be HPV vaccine. Get your HPV vaccine. Everyone 9 to 45 should have an HPV vaccine. You will hear horror stories about it. You will hear awful things about side effects and neurologic side effects and all sorts of crazy stuff. In general, there has been no close association of any serious long-term effects of the HPV vaccine.
Right.
There are case reports out there. There are little things out there that are reported to the vaccine injury, the VAERS sort of database, but they are constantly monitoring the VAERS database. And so all that data is constantly coming in, and they're looking for correlations, and they're not finding anything. The only thing that they found to be associated more with the HPV vaccine than other vaccines is actually syncope. So someone getting the vaccine and passing out.
Right there and then.
Right there and then, usually right there and then. And so obviously probably more of a vaccine sort of
Right.
shot reaction rather than the actual HPV vaccine itself. But it's just interesting that the HPV specifically, when they compare it to even other things like tetanus and flu and other vaccines, for whatever reason, the HPV vaccine does have a higher rate of syncope. So that's, for the most part, the most serious complication of the vaccine that we have shown to happen. And So
And
get
let's
your
not forget our, our male friends, and, they have to get it too. They
yes,
should be getting it.
your male friends, your brothers, in the future, your sons. I have two boys, and when they turn 11, the HPV vaccine is on the schedule at ages 11 to 12. So when they turn 11,
They're
they will
getting
get
a shot.
their
And
series.
you'll be there to catch them if they pass
That's
out.
right. I'll catch them when they pass out, and they won't hit their head, so it'll be fine.
All right, awesome. This was super, very informational, so enlightening. I actually didn't know all the strains of the Gardasil 9, so that was really interesting for me too. Where can people find you on social media? And I know you just got verified by TikTok. So where can they find you on TikTok and on Instagram, and anywhere else that you are online?
Yep, my social media handle is the same on TikTok as it is on Instagram. It's at Dr. Staci T, and that's Dr. Staci T. I'm Dr. Staci T on Twitter too, just without the periods. But that's the primary way to find me and follow.
Yeah, she's got amazing, really informational videos. I'm like learning something new every day. I'm like, I feel like I should have known that.
The whole beauty of it, right? Like
But
even us as smart women, like there's so many things that smart women don't even know
yeah.
that we're teaching. So,
Yeah, no, amazing. I love all your videos. So thank you so much for hanging out with us and teaching us all this good stuff. And I'll talk to you soon.
yeah, thanks.